nothing new. It's just formally gotten its name in the last decade and a half or so. And one of the most important topics that we often miss out on in terms of relevance and importance is bone health, and that's what I'm here to discuss today. So I did speak with Dr. Satya and Dr. Srividya recently, and took a look at a few of the packages that they've been exploring in terms of senior health. And I noticed that there was a lot of stress, or rather importance, given to bone health, and appropriately so, because we're living in a world where people are living longer. That means that people above the age of 65, there's a longer life expectancy, in which time that extra 10 years or 15 years that people have now compared to about 50 to 70 years ago, has offers a time window where people can live well, but also be susceptible to bone-related issues such as fractures, mostly related to falls. There is fragility or frailty fractures. So I'm going to go ahead and share the PowerPoint that I have, and have a discussion surrounding osteoporosis mainly. Let me. Okay, let's do this. Is the PowerPoint visible?
Yes, it's visible. You can go into the share, into the full screen mode, and you can.
Okay, so bone health in the elderly, will be touching upon very briefly upon falls and fall prevention, fall assessment mostly, and then what it is around the primary care, preventive care aspect of bone health screening, as well as current recommendations in terms of osteoporosis management, just an overview. So to begin with, let's talk about fall risk screening in the preventive care setting. This looks very brief compared to what a geriatrician or anybody who is in, for example, in rehabilitative medicine or internal medicine would be doing, because that would be a more detailed evaluation of falls. But in the preventive care clinic, there's a quick 12-second test that can be done, which is called as a timed up and go test, where the elderly person, usually 60 and above, is asked to rise from the chair that they are sitting on, to walk for 10 feet, turn around and come back and sit in the chair. So if they take 12 seconds or more, it's considered as abnormal. So usually it takes anywhere between 12 to 15 seconds, which means that most people do screen for the tongue test abnormally. Why is this important, and how does it sort of lead into bone health? Is because many people end up with bone-related issues, fractures, related to standing level falls. So for example, if they're standing at home, or they're walking, or they're just getting out of bed, or they're getting up from a chair, they tend to have a fall in that situation. So it's not just fall prevention, but we also have to look at strengthening bones so that if they do sustain a fall, which is common in older adults, we prevent that fragility fracture as much as possible. So we'll go into bone health. Bone homeostasis is to the left of the screen. So that's where we have a bone formation and bone resorption in an equilibrium. So the osteoblasts and the osteoclasts are sort of working together in a perfect equilibrium so that bone isn't lost. Now, to maintain bone homeostasis is much easier when we're younger, but as we grow older, there are a variety of factors that come in, including menopause in older women, as well as systemic ailments which lead to secondary osteoporosis or thinning of the bone, in which situation the rate of bone formation is much lesser than the rate of bone resorption. So your osteoclasts are working over time compared to the osteoblasts, so the bone generating cells. Therefore, we have a much more fragile bone, which is highly susceptible to fractures. And most of these at the cellular and molecular level are driven by pro-inflammatory cytokines, again triggered off by reactive oxygen species and chronic inflammation in the body. So this graph explains a little bit about, it has on the x-axis age in years and y-axis bone mass. And the closer dotted line is the male, which is the highest graph. Then you have the female, which is a solid line, and then you have the suboptimal lifestyle factors. That is, it's not really gender related. That's the lowest curve. So the top curve, which represents the male curve, usually the peak bone mass is higher in males.
And the PowerPoint is not running. Sorry to interrupt. The PowerPoint, yeah, now it's good.
Is it working now?
Yeah, Dr. Aarti, you can make it to slideshow so that it will, because, yeah, then it will take the full screen. Yeah.
So it was on slideshow. Is it coming up now?
It's not. No, it's not. It's not.
Not showing up.
We can see the slide, but it's not the slideshow.
Can I just
there is just come down, yeah, next to that.
You okay with this? Is it visible now?
No, there is a slideshow, this one, button there, if you can see.
This button, yeah. But the problem is when I click that button, you're not able to see it. That's why I don't have it on that button. Are you able to see anything now?
Yes, there.
Yeah, you can continue.
Perfect. Okay. So the top curve is the male bone mass. The middle curve, which is a solid line, is the females. And then you have the lowest curve, which is more between the ages of about 20 to 30, we have a plateau in our bone mineral density or the bone mass. That's when we achieve our peak bone mass and we start plateauing. And between about 30 and 40, we continue to have either a plateau or a very, very, very slow decline, which may not be noted on any bone mineral density tests. It's only after 40 that there starts to begin a decline that starts going towards osteopenia, but not so much into osteopenia or -1 standard deviation compared to the average population or the mean. And then by the age of about 50, mid 50s to 60, we start seeing those curves going into the osteopenia range, which means that that's around when they may start showing up on the bone mineral density tests. So this is average for males and females, but in the presence of suboptimal lifestyle factors, which is the bottommost curve, you can have an accelerated osteoporosis because that person never really reaches their best peak bone mass. Even by the age of 20 to 30, you can see that their peak is actually quite low, which means to begin with, their bone mass has been low, therefore predisposing them to earlier and more severe bone loss as they grow older. So achieving peak bone mass and targeting the younger population is actually really important when it comes to long-term prevention of osteoporosis, as evidenced by this graph. Next slide, we have bone mineral density screening. The technologies used in bone densitometry include DEXA, qualitative ultrasound, as well as quantitative CT. The most common one, of course, that we use is DEXA, which is also the gold standard because its accuracy in terms of reporting, in terms of variability between tests is actually more optimal compared to the quantitative ultrasound or the CT. Then you have bone mineral density screening in India. Over 120 million older adults in India at present, but there's no clear statistics on how many are being screened annually. It can be taken for granted that most of the people who do undergo bone mineral density screening in the 65 plus population are actually urban because the rural population does not have much of an access to BMD screening. There are a bunch of foundations and societies that make recommendations as to when we start therapy and who we screen. For example, there's this National Osteoporosis Foundation, there's the Indian Society for Bone Mineral Research, and then you have the International Society for Clinical Densitometry. They all have different recommendations. There is no clear consensus between these societies.
But I think your slides are not moving again. So is there any issue? Yeah, now it's come to that. Yeah.
Able to see? Just let me know if you're not able to. Just stop me and let me know if you're not able to see this.
Yeah. Now it's okay. Yeah.
Perfect. So I've gone through the ISBMR or the Indian Society for Bone Mineral Research guidelines for DEXA screening because this has taken into consideration evidence from Indian populations as opposed to other societies, international societies where even if the population tested is heterogeneous, it does not have an adequate representation of Indian Asian population in those studies. So here we have screening, DEXA screening for women 60 and older, men 65 and older, sorry. Postmenopausal women younger than 60 and men 50 to 64 if elevated lifestyle risk factors like smoking, consumption of alcohol, or if they are on glucocorticoid therapy or corticosteroid therapy. People who have chronic kidney disease, who've had previous fractures, fragility fractures. Women who are in menopause transition with increased fracture risk, fragility fracture before the age of 50, as well as rheumatoid arthritis, diabetes mellitus, malabsorption, daily glucocorticoids, such as a dose equivalent of 5 milligram or more of prednisone per day for 3 or more months. That's considered as a risk factor, glucocorticoid related risk factor for osteoporosis. In fact, when we look at the FRAX tool, if we individually vary each of the risk factors in the FRAX calculator, glucocorticoid has a very significant risk attribution. So the impact of steroids or steroid therapy should not be underestimated when it comes to secondary osteoporosis. And that's why in history, in gaining our history from the patient, knowing whether they've been on glucocorticoid therapy is one of the most important things. So let's go through the WHO classification of BMD by DEXA. We have normal, which is where the T-score. So the T-score is a golden number, as we all know. Normal would be -1 or above -1. Then you have a low bone mass osteopenia, which is between -1.0 and -2.5. So anything up to 2.4 is considered as osteopenia. Osteoporosis is -2.5 or lesser than that. And severe osteoporosis is -2.5 or lesser with a fragility fracture. Why is it important? Because the treatment differs. In a normal individual, in a person with a normal bone mineral density, we just recommend routine preventive care such as walking, maintaining an adequate diet. But when it comes to osteopenia, we do a little bit of supplementation, making sure that they walk 30 to 45 minutes. Osteoporosis is where we start having our pharmacotherapies. How does the FRAX score guide treatment? So there's a lot of noise about the FRAX score. It says it's a tool that can be used either with the BMD or without the BMD. But there's an actual online FRAX calculator, which is quite simple. It has about 10 parameters that we enter. And the National Osteoporosis Foundation guide recommends that if a FRAX 10-year risk of 3% or more for hip fracture or 20% or more for major osteoporotic fracture, in the FRAX calculator, that is the 10-year risk score, then that would necessitate treatment initiation for osteoporosis. So let's say we are not able to do a BMD for whatever reason. If we have the FRAX risk score, that would guide treatment in this situation. Let's go to a little bit of assessment of lifestyle on bone health. So we speak a lot about, okay, we can do a bunch of medications to improve bone mineral density, but how important is it to assess what it is that led to this particular, state of bone health in an individual in the first place? So ethanol or alcohol and bone typically leads to slowed bone formation. So alcohol has an inhibitory effect on the bone forming cells and causes aberrant or interrupted remodeling of skeletal tissue. Let's say that we have an injury or we have we have any abnormality. So the remodeling of the skeletal tissue is stopped by alcohol consumption. Then you have, this is just a complicated graph to say that alcohol basically reduces new bone formation and increases bone loss and release of bone-related minerals like calcium and phosphate. Then you have smoking and bone. So smoking reduces blood supply to the bone. Nicotine slows down osteoblasts, a situation very similar to what alcohol does. And it also decreases calcium absorption from the gut, smoking. So that's something that works as a double whammy when it comes to bone loss. Then you have the impact of exercise and bone. This is a positive impact on bone. So walking or weight-bearing exercise is the single most important exercise which has shown consistent benefits in promoting bone formation in post-menopausal women. It's not even standing. It's not even really like the constant strain. It's not even that which promotes bone formation in the hip and the spine. It's actually the alternation of pressure and the release of pressure that comes from taking steps or walking that has shown the consistent benefit in bone growth. Strength and resistance training, there is some evidence to show that strength training actually protects younger individuals from future bone loss. And resistance training, there is evidence to show that it improves bone density in younger men. So of course, if we were to say that somebody has to do strength and resistance training, which can be more intense than just walking, it's important to know their cardiopulmonary risk factors prior to starting physical training by getting a TMT echo and a PFT. Then the impact of diet and bone. So green leafy vegetables, which contain vitamin C, which of course directly stimulates osteoblasts for bone deposition, are important. Then you have the green and yellow vegetables, which have shown through studies increase bone mineralization in younger years. So when we see younger individuals, of course, these are the kind of recommendations we would be making. The impact of meat, both red and white meat, red more than white, is that it has a high phosphorus to calcium ratio, which increases preferential calcium excretion from the body and demineralizes the bone. So over a long period of time, meat can actually have a weakening effect on the bone and accelerate osteopenia and osteoporosis. Minerals and vitamins, you have calcium consumption spread across meals, not all at once to optimize absorption. Now, what does this mean? Let's say we were to take a calcium tablet. We were to take a shell cal versus actually divide our calcium consumption over breakfast, lunch, and dinner. That same calcium, when it is consumed over a spread out period across the day, has a higher absorption, even if the total amount of calcium is the same. Goes to show that when we have our calcium with our meals, it's absorbed much better than a supplement would be. Then you have your mineral, which is, other mineral, which is magnesium. Helps to convert vitamin D to its active form and thereby facilitates vitamin D to carry out its normal bone strengthening effects on the body. Zinc promotes osteoblast activity. Calcium-rich foods are always better than calcium supplements, like I mentioned before. Vitamin D increases calcium absorption from the gut and increases bone mineralization. Usual RDA is about 2,000 international units per day. Then you have the vitamin K2, through osteocalcin modification, which is important for bone mineralization as we continue to age. So maintaining optimal levels of vitamin D as well as K2 along with vitamin C are required for good healthy bone formation. Supplements and nutraceuticals, there have been a few small studies that have shown benefit of collagen in increasing bone mineral density, few early studies, but it's not formally recommended because there's no adequate evidence or safety data consistently to support its inclusion in routine guidelines. So if there are patients who ask about collagen, I think it's fair to say that there is limited evidence in smaller studies, but it's not a formal recommendation by any society. So let's come to the Endocrine Society recommendations for osteoporosis treatment. Why are we choosing Endocrine Society? Because it has considered 107 randomized controlled trials and compared about like 1,93,987 postmenopausal women, which is a large number, seeing reproducibility of data. The mean age being 66, which is perfect, and the median follow-up of about 28 months, so over 2 years of follow-up. But the gray area is that 55% of who they've studied is Caucasian women. Again, like I said before, there's not an adequate representation of Asian Indian women in these treatment guidelines, or the effect of treatment on Asian Indian women. So second line of tests, let's go through a few things before we go into the treatment. The second line of tests in osteoporosis are CBC, total calcium, inorganic phosphate, alkaline phosphatase, RFT, LFT, vitamin D, or the 25-hydroxyvitamin D, the intact PTH or parathyroid hormone, and TSH. Why are these important? Because they do give us a view into whether there is a possibility that we're dealing with secondary osteoporosis, even if the individual who is affected is a postmenopausal woman or an at-risk older male. Even then, we would be typically doing these once we discover that a patient has osteoporosis on a BMT. Additional testing for secondary osteoporosis, if we suspect myeloma, then we test ESR, SPEP, and UPEP. For celiac disease, we test the tissue transglutaminase antibody, IgA. Then hypogonadism, we check for testosterone in males, estradiol in females. Cushing syndrome, we do an overnight dexamethasone suppression test. And type 2 diabetes, we check for the A1C, FBS, fasting, and postprandial, which is usually included in all of our health checks.
Dr. Aarti, can you please move to the relevant slide? We are still seeing the slide on ethanol effects. Thank you.
So I am moving to the relevant slide, but if you're not able to see it because it's stuck, just let me know. In my screen, the slides are moving. So just pause me and let me know if I'm going to say next slide. If you want. Okay, one second. Hang on. Let me try to do that. Let me just share screen. I think that makes sense. That's a good idea. Perfect. Better? Goal of treatment initiation for osteoporosis. Are you able to see this?
Yes.
Perfect. Okay. So the goal of treatment is to reduce burden of fragility fractures, the morbidity, mortality, and related costs. Osteoporosis, Endocrine Society recommendations recommend that the first line of treatment for osteoporosis is bisphosphonates, namely alendronate, risedronate, and zoledronic acid. Then we typically reassess the fracture risk within 3 to 5 years in postmenopausal women. We can do it with a FRAX score, but typically the bone mineral density recheck through a DEXA is recommended between 1 to 3 years after starting bisphosphonates. If low risk, then we do a bisphosphonate holiday. If high risk, if they continue to have a high risk of fractures, then we continue the bisphosphonate. A holiday from bisphosphonates can last anywhere, again, between 3 to 5 years, and it is a temporary, even though it's a long term, 3 to 5 years is quite a long time, it's still considered as a temporary interruption in bisphosphonates before we restart therapy after 5 years. Alternate first line for high-risk postmenopausal women is denosumab. So denosumab is the agent that is parenteral agent, not an oral agent, which is considered in case a person cannot tolerate bisphosphonates for any reason. So that would typically be given at 60 milligram subcutaneously every 6 months. That would be SC, not CS. Drug holiday not recommended because the drug effects reverse if not continued every 6 months. So this is where we don't. Bisphosphonates can be considered for drug holiday, but not denosumab. Then we have teriparatide or abaloparatide, which is your PTH-related protein analogs recommended in women with very high risk of fractures like severe or multiple vertebral fractures for up to 2 years, not more than that. Again, it's considered for anywhere between 6 months to 2 years, teriparatide. After completion of the above, we maintain the gains that we get with teriparatide with anti-resorptive agents. We can put them on a bisphosphonate or denosumab. Then we have the selective estrogen receptor modulator or the SERMs and hormonal therapy. These are the ones that target directly through the estrogen receptors. First one would be raloxifene or bazidoxifene. Postmenopausal women with a low DVT risk. This is very important because these agents would increase the risk of deep venous thrombosis and pulmonary embolism. So only if they have a low DVT risk overall, and for whom denosumab or bisphosphonates are not appropriate, but they have a high CA breast or cancer of the breast risk. So these would be like a very select or a niche population that we can think about. Let's say a patient actually comes in with a strong family history of breast cancer, but they have a low risk of DVT and they cannot tolerate alendronate. Then we can consider raloxifene and baziroxifene in them. Then we have estrogen or tibolone only in under 60 or women who are less than 10 years since menopause, in whom denosumab or bisphosphonates are not appropriate or who cannot tolerate them, who have had a hysterectomy because we don't want the estrogenic activity on their endometrium, with significant vasomotor climacteric symptoms, that is menopausal or menopausal symptoms, without any contraindications or prior stroke or MI or breast cancer. So we don't want them to have any of these conditions. Only then would they qualify for estrogen or tibolone therapy. And of course, they have to be okay with accepting the hormone therapy because it comes with significant risks. Then we have calcitonin. So in postmenopausal women who cannot tolerate the above medications or they're not appropriate, any of these, bisphosphonates, denosumab, SERMs, estrogen, teriparatide, then we think about nasal spray calcitonin in these patients. Who should get calcium and vitamin D? This is a big question, right? Like actually all postmenopausal women with a low BMD, regardless of whether they're osteopenic or osteoporotic, with a high fracture risk as an adjunct to osteoporosis therapies. So this needs to be given in addition to the osteoporosis therapies that they will be on if they're osteoporotic. Now, is calcium-rich food a good substitute for calcium supplements? Actually, yes. I used to think that, when I was a trainee, I used to think that calcium-rich foods, milk, green leafy vegetables were not adequate. But turns out that their absorption is far superior compared to the calcium pills or the supplements that we usually take, which is all at one go. The RDA is about 1,000 to 1,200 milligrams per day in older adults. Monitoring treatment response to osteoporosis. So bone mineral density monitoring is typically done 1 to 3 yearly with the DEXA of the hip and the lumbar spine. And we can also consider bone turnover markers, but the practicality of really doing them is not so much, because getting a C-terminal cross-linking telopeptide or a procollagen type 1 N-terminal propeptide is not very easy. Many of these are classic send-out tests and they take a while to come back. So, and they're also expensive. So getting a DEXA would be far superior and easier because they're all in facility. Additional diagnostic considerations. Oh, sorry, previous slide, there's one more thing is the bone turnover markers can also help with short-term monitoring adherence to treatment. For example, if we're giving an oral agent, which is dependent on the patient and not on us, then monitoring treatment adherence, these are good ways to do it, the bone turnover markers. Additional diagnostic considerations. So this is something that, that I learned only with time, is that DEXA is gold standard, but is it truly above error? Now, there are conditions in which you can have a false negative or a falsely normal DEXA. For example, a patient with osteophytes, which is, by the way, very common as we age. In fact, over the age of 30 to 35, we already start seeing osteophytes on X-rays, on MRIs, on imaging techniques. Then degenerative disease in the spine or the hip. Healed fractures, which are also very common in elderly population. Avascular necrosis of the hip, which is, again, common in the glucocorticoid-associated elderly. Then you have benign or metastatic bone-forming lesions, which can also come up as a falsely normal bone mineral density, even though the underlying bone mineral density is actually poor. Then you have a falsely abnormal DEXA in patients who had a laminectomy or lytic lesions of the bone. An ideal DEXA report would also include the possibility of artifacts like aortic calcification, which is also, by the way, very common in elderly, the calcification of the aorta, which is around the same level as the DEXA spine considers. Then osteosclerosis, which is hardening of the bone, which happens with age. Then you have fractures and quality of the study. And it would also include have exclusion of any vertebrae from the disease with the corrected score. For example, if you're considering L1, 2, 3, and 4, let's say L1 and L2 are having an artifact. Typically, a good DEXA report or a reporter, someone who's reading it, interpreting it, and giving the score, and would typically exclude the L1 and L2 and only consider L3 and L4. But that does not happen as a standard throughout, and this is something we need to keep in mind to increase the accuracy of or the positive predictive value of these tests. Then, if an artifact is present, then better to go by the HIP score than the L-spine score. When we have the images of the DEXA on the sheet, on the printout or the report, along with the actual results, it helps because we're able to see many of these artifacts on the image itself. And we're able to see whether it is even reliable to go by the L-spine score, or should we consider the HIP score alone. So the takeaway being HIP score generally more reliable than L-spine score if we are worried about artifacts. Additional treatment considerations are FRAX calculation can be done with or without BMD, and that can be used to guide treatment. Consider starting first-line agents within 2 weeks of a hip fracture. Frequent falls lead to increased fracture risk, which is not represented by conventional screening of FRAX, which is why actually having a fall screening in the preventive care setting would be very useful, like the timed up and go test, which doesn't take too long. Then you have a false negative DEXA. Like I mentioned, osteophytes, degenerative disease, avascular necrosis, bone-forming lesions, falsely abnormal DEXA and laminectomy lytic lesions. And ideal, I think this is just the same slide. I've put it in the other slide, I'm sorry. Osteoporosis management. Let's go into starting. So how I would typically approach it is starting weekly oral alendronate or izidronate if no contraindications. So typically contraindications are, let's say somebody who has very, very bad like reflux disease, or somebody who has quite unbearable dyspepsia symptoms. They may not do too well on alendronate or izidronate because typically these medications have to be taken once a week in the morning on an empty stomach, and they're not supposed to lie down after taking it for about an hour and to consume nothing else. So it can be quite disturbing to the stomach lining and can cause significant reflux symptoms. Vitamin D therapy only if indicated. Ensure no polypharmacy, because many patients who come to me with a low vitamin D or a normal vitamin D, many of them go on a supplement, maybe initiated by another provider. But if you look at their medication list, they're on a multivitamin and a mega dose supplement and a calcium and vitamin D supplement. So that's a lot of vitamin D. Can lead to toxicity, so need to be careful about that. Advise walking of 30 to 45 minutes daily. Suggest a smartphone walking tracker and iterate the importance of keeping a log of the steps per day if the person is truly into participating in their treatment and taking ownership. Adopting a specific goal-based approach rather than keeping a general, like saying, advice walking, letting them know that, hey, walk for 30 minutes every day without a break would actually help to make it more specific for them and help them meet their end better. Osteoporosis management continued would be to reassess. So now the first part is to just how we initiate therapy. The second slide is about how we monitor the treatment or monitor the therapy, whether they are following it. I would reassess in about 8 weeks for compliance or adherence, because for some reason, 3 months seems to be like they disappear into the oblivion and they don't follow through. So 8 weeks through non-punitive screening for verbal teachback of correct technique. Are they able to take their medications on an empty stomach? Are they able to explain the correct technique of taking their oral medication? Side effects, missed doses, rather than asking, are you taking your pills as advised? If issues with adherence due to side effects, consider parenteral or alternate first-line agent if no contraindications. We've typically seen that when it comes to bone mineral density, because there's no immediate perceived risk, a lot of patients fall out of the treatment. They say it's only once a week, it's okay if I miss a dose. So treatment adherence is actually more difficult in these situations, in which case we can consider parenteral agents after due discussion of the risks and contraindications. Also, rechecking vitamin D in about 8 weeks if correction is initiated. Vitamin D can show up, improvements can show up as early as 7 to 14 days after we initiate therapy with vitamin D. So in about 8 weeks, we'll get to know whether we are appropriately correcting the vitamin D or not. And then a 6-month follow-up to ensure that things are going according to plan, that they're exercising, that they're taking all the supplements, have they had any falls, any further increased risk in fractures. And then we repeat the DEXA scan in about a year. So that brings us to the end of the PowerPoint and opens us up to discussion surrounding bone mineral density, and I would love to learn your practice considerations and maybe go through a few questions.
Hi, thank you, Dr. Aarti. It was a very in-depth discussion about osteoporosis and bone health. A very, very important message about that we need to, we need to put a lot of work and thought into elderly people, especially if you want to prevent fractures. And then the treatment, of course, is a lot more painful once you're fractured. Then you have to go through surgery. And most people are diabetic, so they have a lot of autonomic issues along with that. So how do we screen? I mean, how do we create this awareness that geriatrics with long-standing diabetes to prevent the risk of fall and preventing osteoporosis, like that we would want to know, how do we go from there? How do we start from there?
I think that's a very relevant question, because as we are growing older and we have our own parents, we have our grandparents, all of them sort of refusing to undergo unnecessary tests, so to speak, because they don't want to discover new problems. But the truth is, maybe helping, I would usually tie it to a story. There's usually one older adult in the family they've witnessed going through a hip fracture and going through the morbidity and the immobility, the loss of functionality and independence and autonomy, something that rings very true to them, associated with that fall, associated with that fracture. Sort of explaining that this is not a thing that is unpreventable. This is preventable. This is something that can be looked into. And if we manage it early, we'll be able to mitigate a lot of the effects of it. And that the test, most importantly, is painless. The treatment is painless. The monitoring is painless. So it's not a very cumbersome, burdensome thing. It is actually a lot of gain for very little effort, in my opinion. It's not like taking insulin or poking yourself every day to check for diabetes and monitoring. It's very straightforward. So maybe explaining the trajectory of monitoring and treatment would help them a lot. Tying it to a story of an elderly person who they have witnessed in the family would help a lot, like bringing it from like an angle of emotion. And most importantly, like what you're doing, having that focus on prevention, on making sure that every older person above the age of 60 gets screened for their bone mineral density through the DEXA scan and undergoes periodic screening. So even we as physicians, when we emphasize that every year we need to follow up and get that DEXA done to see if the pills are actually functioning. It's not just take the pill, go home, come back after 5 years when you don't know what to do when you have a fracture. So giving them that clear follow-up plan lets them know what to expect.
And also, I think it is important that we create an awareness among the family and the caregivers that these people are more vulnerable to fall. So you need to have, like for children, we make a safe zone. So we need to make a safe zone for the elderly people also. And longevity is the science today. I mean, we are all living longer and longer. And the more and more elderly people we are seeing they're going into dementia, and they have sleep insomnia. So then again, their risk of fall is very, very high. So it's very important that we screen osteoporosis, take care of all the other parameters. So how do we increase the awareness among caregivers?
I think among caregivers it's not as straightforward as your target population, which is older adults, because older adults you can say, okay, here's how you prevent it, this is what you do. Among caregivers, again, letting them know that these tests are available easily, and an ounce of prevention is worth a pound of cure. So we may not be able to completely mitigate falls. Like if you have an elderly person at home, the message would be, if you are a caregiver, would typically be, we may not be able to completely reduce the risk of your elderly loved one falling to zero, but we can do a damn good job with the kind of agents we have to reduce the risk of fracture from that fall. So even if they have a fall, if we do this particular, if we take this measure, we can really reduce the risk of morbidity, mortality, and disability. Most importantly, when we say that, your older adult is going to continue to function the same way, and this is a really easy way to think about this as a bone vaccine. Like in very simple words, this is like a vaccine for bone health. It may not be a true vaccine, but like in a way that people understand, it is true preventive or protective care or a shield around bones. That's how I would put it. And honestly, like, if we explain to them that it is a once in 6 monthly injection or it's a once in a week pill, I think caregivers are more than enthusiastic to participate in these things, because it is up to them to have to take care of the elderly person if they do become disabled. Not in a burden, not in a way of burden, but like they understand the pain of it. They don't want to see their loved ones suffering. So actually educating the caregiver is more important in these situations than the target population.
Thank you, Dr. Aarti. We are open to discussion. Feel free to, or either you can put it in the chat box. Hi, Sujata.
Sujata here.
Yes.
I'm seeing a patient in between. I'm turning to ask a question. This is regarding calcitonin spray, nasal spray. Do you recommend it, and how long it can be safely given?
So calcitonin spray is typically only given as a last line agent. If you go by our discussion, it is not one of the best methods because it does not have a consistent response. Its response rate is quite limited. The first line always remains bisphosphonates if it is tolerated orally. Otherwise, even the parenteral bisphosphonate zoledronic acid is perfectly fine. The compliance with those, response to those is much, much better and more well documented than calcitonin. In terms of duration, I'll have to look it up and get back to you because it's been a very long time since I prescribed calcitonin spray for a patient.
This is for my father, hyperparathyroidism. So there are many ifs and buts, and vitamin D not to be given, calcium to be kept low. So with that caveat, so I started using this, and maybe I will get back to you one-on-one on that particular case. Okay.
Sure, I'll be happy to answer that question. Let me look it up for you and get back to you because his situation would be slightly different. He is not just a primary age related, it would be secondary osteoporosis in his situation. And yes, I can understand that your first line agents typically may not work. So yes, calcitonin spray would be indicated for him, and I can get back to you with the dose and the duration.
Sure. Okay. Thank you. Thank you. Yeah. I'll be glad to
Thank you very much.
With you later. Okay. Thank
you. Thank you. Thank you, Dr. Sujata.
Yeah. So do we have any other questions? So like I mentioned in the beginning, we have recurated elderly health check in which we have rolled it out in Chennai as of now. And it has a lot of investigations. So Anusha, can you quickly share your screen? We can go through it. Also, we have, like what Dr. Aarti said, many places do not have FRAC score, do not have an DEXA machine. So we have actively encouraging the use of FRAC score. So these are the checks which we have rolled out for the senior citizen, in which if you go through it, you will realize that we are trying to bring in a little more assessments to prevent fall, flexibility and strength and balance, sleep, audiometry, dental screening, the screening which are more important, which are usually missed unless there is a problem. These elderly people do not go to the doctors. So we are trying to bring it into the screening program itself. You will also see that some of the tests which were not there before have been added, and some tests have been removed, whichever works for the doctors and that particular unit. There's a logic behind this. But I would also like to run you people through how the FRAC score is done. Dr. Anusha, can we have the link for the FRAC score? Yeah, so this is a calculation which opens up as a click point, and it is a separate link. Most of these are available on our history, whether the age, the date of birth, the gender, weight, height, previous history of previous fracture, any history of parents, family history of fracture, smoking, glucocorticoids. Essentially, when we say glucocorticoid, it means if there is any autoimmune disease or if the person has gone through any malignancy, has received treatment, or rheumatoid arthritis, secondary osteoporosis, again, if somebody has used steroids before, or if they have undergone radiation and chemotherapy, and use of alcohol. If there is a history of femoral neck BMD available, that is a previous DEXA report is available, you can say it is available. Otherwise, you can say not available, and it will calculate the score. If you want, can we quickly run through this, Anusha? Yeah, so this is how it will come out. But as of now, we don't have it in Mad Mantra, but it can be captured. Whatever is your risk score, it can be captured as a free text, and accordingly recommendation can be done whether the person needs to go for a DEXA scan, or we can wait, or we can start the patient on a vitamin D and a calcium treatment, and then take a call about getting the DEXA done. So we have a lot of options. There are a lot of units across India which do not have DEXA machine. So for that, we have developed this FRAC score. We will see in future how to incorporate it into the Med Mantra also. So with this, I will stop here, and I'm looking forward to your questions. Both me and Dr. Aarti are here to answer your questions if there is any specific question you want to ask.
So, Dr. Sujata, I just wanted to let you know, if you're still around and you're listening, I looked up the dose of calcitonin for you. It's typically described as 200 units or one spray into any one nostril per day, and you have to alternate the nostril between days of week. To maintain safety, you would typically limit it to less than 6 months of use at a time, exactly. Not to use for more than 6 months.
More than 6 months. And like you told, calcitonin is used as a last resort. I would rather look at the cause of hyperparathyroidism and treat that than go in for calcitonin. But I'm not sure. I'm sure Dr. Sujata is under a treatment. Her father is under a treatment of an endocrinologist. We can, always get back to us on that. Yeah. I think somebody has put something in the chat.
Get back to you.
Yeah. Okay, that's right. So if there is no question, thank you very much, Aarti. I think we've had a good audience of around 47 doctors across India, and we are also recording these sessions. We also have a YouTube live streaming which is happening parallelly, and we also have doctors who are from outside the Apollo ecosystem, corporate doctors and also we will be sending the video with the key points of the talk, and looking forward to more discussion from everybody. The next session will be in first week of January, and we are going to take we're going to have a cardiologist from Hyderabad, from Secunderabad Apollo Hospital, who will be joining us for the talk. So looking forward to everybody being there with us on the Talk Pro Health in January again. Hello, Dr. Nyogi, how are you? Do you have any comments, sir? Good afternoon, sir.
Hello.
Yes, sir.
Yes, I am listening.
No, you please, can we have your feedback on the talk and your opinion about geriatric health?
Yeah, I'll do that.
Do you have any? So I think with that, we will once again thank you very much. Yes, sir.
It is very interesting topic, and because osteoporosis is so common, especially among ladies and young children also.
Yes.
It is quite right. Have presented this important matter.
Yes. Yes. Yeah, that was the idea behind it, to create awareness that the falls and the osteoporosis is something which kind of goes linked with many diseases, whether somebody is diabetic, they have dementia, they have vascular diseases. Osteoporosis is something which sets back all treatment. Somebody who has a fall, fractures, whatever they are going through. They develop pneumonia after that, they develop urinary infection because of probably prolonged catheterization. So we wanted to create awareness that it is very easily detected, whether we do a DEXA scan or we do a FRAX score. And there are other scoring. FRAX is one which we use because it is very simple. There are 4 or 5 other scores, but FRAX is easy to use, and anybody can go online and do the calculation. So it is important that we be aware that there are symptoms and systems available for us to make use of, and then refer to the right person for the treatment. That is the idea behind any pro health talk also. So we had an in-depth discussion with Dr. Aarti Kannan. Thank you very much, Aarti, for taking out time from your busy clinical practice. I know how busy you are, and really appreciate all your input, and looking forward to many more such discussions. Thank you very much, sir.
Thank you.
Yeah.
Thank you.
Yeah.
Have a good day.
Thank you.
Bye.
Thank you. Bye.
Bye.